Welcome back to the show, folks. Today's guest is a repeat guest. She's a fan favorite. Her name is Dr. Suzanne Turner, and she is the founder and medical director of Vine Medical in Georgia. And she is an incredible educator as well. Suzanne teaches for A4M and a bunch of other places as well. She's a big educator in the peptide space and also in the regenerative medicine and healthy aging space. Today, we talk about lab tests and lab results. What are the numbers you want to be looking for when you're interpreting your blood work? I mean, we know that the ranges are huge. We want to know what's that narrower range? What is the optimal range for blood work? So this was Suzanne's idea. It's a great episode, and stick around till the end because, of course, we get into peptides. I mean, we couldn't possibly let Suzanne go without talking about peptides. So if you're looking to get in touch with Dr. Suzanne Turner, you can find her on Instagram, Dr. Suzanne Turner, and also email vinemedical.com. And that is her office in Georgia. And you guys know where to find me. If you're looking to connect with me, you can come to my website, natniddam.com. And I've just launched in the past month a new community called on Mighty Networks called BSP Community. It is private. It is not censored. And there's going to be a ton of value in there for you guys. So come check it out. Go to natniddam.com and look for the tab BSP Community, and you'll get a whole list of benefits there. And of course, you can find me on Instagram at Natalie Niddam, and still on Facebook in the Optimizing Superhuman Performance group. So lots and lots of places we can connect. Thank you so much for being here. Thank you for your comments, your questions, and everything else that I get from you guys. I so appreciate you. Hey, folks, just a quick reminder that all of the information presented in this podcast is for information purposes only. No medical advice, no diagnosing, no treatments suggested here. Before you try anything that you hear about or learn about here, make sure that you check with your medical provider. Welcome back to the podcast, Dr. Suzanne Turner. It is such a pleasure to have you here today.
Natalie, what a treat to see you. I'm so glad to get to spend some time with you.
Oh, me too. I've been looking forward to this podcast forever. I'm like, yes, we have a date. All right. These episodes are always amazing, guys. If you've listened to any of my past episodes with Dr. Turner or heard her speak on anybody else's podcast, you know that we're in for a beautiful ride today. So what we're going to talk about today, and this is Suzanne's idea, which I think is brilliant. We're going to talk about lab tests, like basic metabolic lab tests and what they can tell you, and also give you some ideas of what are the optimal ranges that a functional medicine practitioner is going to be looking for versus maybe a more conventionally trained doctor or even the labs. Like the labs, I think they establish their ranges, and you can speak to this better than I can, Suzanne, but I've heard that it's not arbitrary, but it's not particularly scientific or functional in the way they establish those ranges. And so a lot of people are being missed while they're, as we're progressing towards an imbalanced state, we miss those signs. And so by the time we're trying to get back to balance, we're so out of whack. It's just a longer road back. So maybe
exactly. So most labs, I think, are done on a bell-shaped curve. We know that from high school, taking our exams and trying to get the best grade we could. And so the middle of that bell-shaped curve is the mean. And then we take, one standard deviation from that and then two standard deviations, which is where we decide what normal is. And so normal changes over time because of the change in population, the change in people who are getting the test done. It's obviously skewed towards people who are going to the doctor. So people who don't go to the doctor aren't getting their tests done. So we aren't catching those people either. So it is a skewed population of normal. And so you have to realize that just because if you are symptomatic, but you fall outside or inside the range of normal, does that mean that you are normal? If you are asymptomatic, but you fall outside, does that mean that you are abnormal? Do you have to treat a lab? And of course, we always are taught in school, never treat the lab, always treat the person. And so it's easy to fall outside of that as you are a regular practitioner, because you don't treat the person. You have 7 minutes, so you don't have time to do that. And as we have provided ourselves, because of the different kind of practices that we have as advanced medicine or integrative medicine practitioners, as we have provided ourselves more time, we actually are able to do a little bit more specialized medicine. Some of the labs that we do take a lot longer to interpret, and we'll go through some of those as we keep talking.
Amazing. Yeah, no, I love what you just said. And I mean, I think a case in point with that one, the most common thing we see is with thyroid patients, right? Like treating thyroid it's a bit of a nightmare. I mean, some people need to have a higher TSH number. I mean, we learned this when I was doing my training around the genetic testing that I use. Some people genetically need a higher TSH number to be what their normal is. But with the ranges, the way that they are right now, there's so many people that are subclinically, like they're not symptomatic, and yet they're subclinically hypothyroid kind of thing, and they're not being treated, and they're just getting worse and worse. And to your point, then you get the people who are getting the treatment and they still feel horrible, and their doctor's saying, well, it's all in your head because you had this lab result, I gave you the medication, it's doing its thing, so clearly there's something wrong with you. And you're like,
so you must have a Prozac deficiency.
That was the last podcast we did together.
Yeah.
And you get these poor people walking around thinking, oh my God, and then their cholesterol goes off the charts and they're put on a statin. And we'll have that conversation later when we're talking about LDL, HDL. But it is a bit of it's a bit of a whirlpool of like this vicious circle of things that feed each other. So, okay, so where are we going to start?
Well, staying on the subject of thyroid, let's start with what tests do we do for thyroid. And so some of this is going to be, hopefully, I'm hoping, Natalie, that it'll be somewhat you and I both getting to learn from each other about what we both do. So I'm excited about that. But what I typically draw for a thyroid patient, if I have a patient who comes in with classic thyroid symptoms, so let's say they have fatigue, they have weight gain, they have their bowels are moving slowly, they feel sluggish and slow, they're cold sensitive relative to other people, they may be experiencing some hair loss. If we have one of those patients and their pulse rate may be lower, their physical body temperature in the morning may be lower. So if we have one of those patients, I'm probably going to draw a TSH, a free T3 and free T4, a total T3 and total T4, although I usually limit using those if their free T3 and free T4 don't make sense. So if I'm trying to just sort of limit the 8,500 lab tests that I'm going to do, I'll skip the totals, but just get the frees. Then I'll get a reverse T3 and both antibodies, thyroglobulin and thyroid peroxidase. And then I like to get an SHBG, because SHBG, sex hormone binding globulin, is affected by thyroid level. So if your thyroid level is really high, your SHBG is also going to be high. In a perfect world, you'd have a zinc, in a RBC zinc, you would have to get a cellular level for that. So you can draw blood, when you get a blood test, you can either get a serum blood level or you can get a RBC level. This is testing for how much is actually in the cell itself. And so in a perfect world, you would have, if I had everything I wanted, I would get an RBC zinc level to find out RBC selenium. You could do the several micronutrient tests out there that are available. You could do a hair specimen. That's a good way to catch some things, as long as they're not using selenium containing hair products,
right,
which would throw
them
off.
Right?
Say it again.
That the dandruff shampoos?
Yes, exactly. Yeah. So those kind of throw things off a little bit if you can get patients to not use those for a little bit. But you can do, a lot of micronutrient tests are helpful. They either use white blood cells or red blood cells as their source. And so you're getting a really good cellular measure. I've used the Vibrant test. I've used the, what's the one that begins with S?
Cell has a good one, don't they? The SpectraCell.
SpectraCell has a micronutrient test. I've had some question about their micronutrient testing because we've sent a couple of specimens from the same patient and gotten different results on the same patient. So that's a little
happens.
But I think that they generally have a good product, and it seems to correlate with what the patient's symptoms are.
Okay.
And then Vibrant does it. And then you can do a Genova test. So Genova has a test called a NutriVal.
Yeah. That one.
The nice thing about the NutriVal is it gives you not just what's my B12 level in my blood, but it looks at what does B12 do in the body. It looks at the precursor and the product of what B12 does. And it tells you, is there too much of the precursor suggesting that there's maybe not enough B12, or is there an overabundance of the product suggesting you may be overtreated with B12, which isn't super common, but possible. So that gives us a more functional picture. Yeah. If you had all the money in the world, you could certainly do both a micronutrient test and a functional test, which would give you a lot of good information to move from, or maybe confuse you more. But I think those are all really important. And so we'd go back to the beginning and talk about thyroid. My goal range for a typical TSH, and keep in mind, this is what your brain produces in response to the thyroid level that's in your brain. Mm-hmm. So it's not taking into account what's happening in the body. It's not taking into account what's going on elsewhere. This TSH is specifically produced in the brain in response to how much thyroid hormone is there in the brain, specifically at the pituitary. So lots of factors can affect that are unrelated to what's happening, let's say, below the blood-brain barrier. Yeah. So the TSH is helpful, but it's not the end-all be-all for thyroid disease. And so if the TSH is the only thing that you're going by to measure, this is going to be a problem. I like that level to be between the TSH to be between 1 and 2 if possible. I do have some patients that we push more than that, and there's lots of various conditions where we would change that. But just for the general population of average person, 1 and 2 is probably a good range, somewhere between 1 and 2. Mm-hmm. The lab range is going to be somewhere between 1.5 and 5, somewhere in there. Yeah. I think we're talking about overall normal versus optimal. Yeah. And you'll hear me reference that over and over again. Mm-hmm. If we're talking about a free T3, this blood test should be drawn in the morning, fasting. If you take thyroid medicine, it should be taken 4 hours after your thyroid medicine. The blood draw.
What it's doing. Yeah.
Yes. Yeah. If it's taken too close or too far away from that blood draw, then you're going to affect your free T3 level. So if I get something that doesn't make sense to me, I'm always going to go back to the patient and say, hey, did you have your blood drawn? Was it 4 hours before, like we've talked about, or was it longer than that or shorter than that? And it was, you had just taken it. Okay, so no wonder your free T3 level is so high. Mm-hmm. We look at free T4. And so free T3, we want to be at least 3. That would be sort of the bottom end of my comfortable level for optimal function. I think the normal range is between 2 and 4. Yeah. 2 and 4.5, depending on the lab. And so I really like that to be on the high end of normal, somewhere above 3. And some practitioners even push it 3.5 or greater. Yeah. And it really is based on the patient's symptoms. If they're very hypothyroid symptomatic, you want to push that higher. If this is a patient with it just depends on the patient. So that's my good bottom end of my range is at least 3.
I have a question for you. Where do you see iodine fitting in on this? Because so many, like I've been doing this Lugol's iodine test on my arm. So can I tell you that it lasts on my arm for about 10 minutes? Like gone. Almost like, so what the Lugol's iodine test is, for those of you who don't know, is you take this, you buy Lugol's iodine and it's dark brown. You drop 4 drops on your arm, on the inside of your forearm, you rub it in, it's going to leave this crazy stain. And then the idea, you're supposed to do it at bedtime and the idea is you want to wake up in the morning and still have some stain. I can put it on in the middle of the day and within an hour it's vanished. And even the fingers that I used to rub my arm it's gone.
What are you doing about that?
I'm doing it more. I think I should be bathing in it at this point.
Mm-hmm. I had a teacher in elementary school who used to bathe in iodine so that she would be tan all the time.
Oh yeah, that's unfortunate. Yeah, no, and I think I'm going to have to, as much as I don't like the taste of it, start putting a little bit in water and drinking it, because I don't use fluoride toothpaste. I don't swim in chlorinated pools. Like, I live in a place we're so far from the ocean, and I don't use iodized salt. We're all doing those things that we're told to do. Use sea salt, use this, use that. And meanwhile, we've left ourselves in a position where we're not getting iodine from anywhere anymore.
Exactly. That's a tough one. And we're not eating as much fish because the fish has mercury, so we're not exposing ourselves. Kelp isn't our favorite food most of the time, so you're not getting very much of that.
Yeah.
People are allergic.
Yeah. And I mean, are they allergic really? But who knows? But definitely getting iodine in the diet, I think. And so I'm just wondering, at what point because there's an iodine, isn't there a urine iodine challenge test that you can have people do also to determine how deficient they may be?
Yes. And I think that's probably the best way to go if you can get them to do. Yep, exactly.
It does involve keeping a jug of pee in your fridge for a period of time. I think it's a 20 sell sometimes.
And it's so important because it's not only the thyroid where it's important, but also with all of your hormones, the hormone receptors all require iodine for optimal function. So it is a critical piece of information for us to gather.
Yeah. Okay. Anyways.
And then reverse T3 is so important because if your reverse T3 is high, it's the poor man's mitochondrial dysfunction marker. So if we're talking about how do we check for oxidative stress, this is the way to do it, is with a reverse T3. If your reverse T3 is high, I'm looking at either you're overdosed on your T4, or you have some sort of mitochondrial dysfunction. And so both of those, I'm going to, the first thing I'm going to do is dial down. And this is the hardest thing for my patients to understand is if your TSH is high and your reverse T3 is high, I'm going to dial down your Synthroid if that's what they're on. And they're like, wait a minute, that doesn't make sense to me. Please don't turn down my Synthroid. But I have to, because that reverse T3 blocks all of your receptors. So it should be in a 2-to-1 ratio with your free T3. And remember that those are measured in different, at least in the United States, they're measured in different measurements. They're in picograms and nanograms. So you have to do the conversion, but it should be a 2-to-1 ratio. A simple rule of thumb is your reverse T3 shouldn't be greater than 15. That's in the United States measure.
It's less than 15.
Yes.
And meanwhile, your T3 should be around, the free T3 is over 3.5.
Over 3. Over 3. Yeah. And those are really the ones that I make the most fuss about. The rest of them, I'll be more flexible with ranges. The antibodies, I know the antibodies, a lot of labs will say that anything less than 40 is normal. I say, why do you have any thyroid antibodies? That doesn't make sense to me. I don't want you to have any. So that's the first thing. If you see thyroid antibodies are less than 40, but they're considered normal, the reason I'm concerned is because I don't want you to have any.
Yeah. No,
so we'll begin to address that. Okay.
And so, okay, well, that's thyroid. And then, so at what point do you check with your patients about iodine or exposure to other halogen compounds that are going to block the iodine, just like the RT3 blocks the T3 you want, the fluorines and those guys are going to, kind of muscle in and block the iodine from doing what it needs to do.
Well, especially if you're seeing them have trouble with that, I'm visioning it in my mind, how the cascade of how it works. If you're seeing that they're having difficulty making that conversion from T4 to T3, or if you're seeing that they're having difficulty specifically making the T4 in the first place, that's really where I'm going to start to investigate iodine. Hey, so I'll do their initial visit. I might ask some of those introductory questions. Hey, why might you have you sound a little hypothyroid. Why might this be the case? Let's draw your blood. And when we get those results back and it looks like, yes, you're having trouble making it in the first place, T4 is 4 iodines, T3 is 3 iodines. And so if you're having trouble making it in the first place, is this because there's a interference? And bromine is everywhere, all the fabrics, all the beds. Do you have a new bed? Do you have a new sofa? Because all of those are made with, are protected with a fire retardant. Yeah, that's going to be damaging to you. A lot of pools now are made with bromine instead of being made with chlorine, because no one wants a chlorine pool. And so now you're bathing in something that is protecting you, or that's preventing you from being able to absorb your iodine.
Wow. Yeah. Okay. All right. Well, that's thyroid. Is there anything else on thyroid, or are we ready?
Yeah, let's move on. Because I want to make sure we stick with the labs and get those specifically addressed.
Yeah.
I think the next thing I want to talk about, because I think there's so much to learn from a very simple things you can get from LabCorp and Quest, from any labs, from Boston Hearts, who I usually use. The things like a complete metabolic panel, complete blood count, and a lipid panel that you get from them. Those are the simple things that we can draw. And almost everyone, when you have a physical from any doctor, is going to probably get at least those 3 done.
Yeah.
So I think we're going to see quite a bit of difference. Again, the idea of the bell-shaped curve. There's research that came out in 2014 that demonstrates that a fasting blood sugar greater than 87 increases the risk of developing diabetes by 6% for every point above 87.
Oh, geez.
So that's my range now. I say, if I see the normal range is less than 100 in most labs. They'll say for blood sugar less than 100, they'll call it abnormal. So my patients balk at me. My new patients always balk at me. They say, well, it says it's normal. Nope. And the research says for every point above. I don't want to wait until you have diabetes before I say, here's a problem. So for fasting blood sugar greater than 87, this is just telling me there's already some insulin resistance at work. There's already something going on that we need to address. I'm not saying that you have diabetes. I'm saying, let's not ignore it until it shows up, until diabetes shows up. Let's begin to address the metabolic things that we can in the meantime to prevent you from developing diabetes 10 years from now.
Yeah, no, I think I think it's huge. I think I was telling you, I just put in a continuous glucose monitor, and it's come to my attention that my blood glucose numbers are higher than they should be, which is it's a little bit shocking, So I'm sitting there going, okay, really, what up with that? This is not acceptable. And if I spoke to a conventional doctor, they'd be like, oh God, you're fine. You're fine. You're fine. And I'm like, no, I'm not fine. I want to be better than fine.
Which monitor are you wearing?
So I'm using that's a good point that you're going to go to. I'm using the Freestyle Libre 2, like the second version, which is supposed to be better than the first. But I've heard real horror stories about how inaccurate they can be sometimes. And we were at our cottage, and then yesterday was my son's graduation. So I haven't actually had a minute to sit with my keto mojo and do a finger prick, because this is interstitial blood sugar. It may be that this CGM is actually poorly calibrated. So it could be that this is a tempest in a teapot. But to your point, we don't want to wait.
Yes, I do like that monitor. That's the one I recommend. And mostly because it's fairly inexpensive if you're buying it with cash.
Yeah.
It's $100 for 2?
Yeah, no. So in Canada, it's more expensive than that, but I can get mine at Costco.
Okay.
So yeah. It's $100 each.
Okay.
But we don't need a prescription for it.
It's great. I've had a couple of patients with sleep disorders that we found out they were hypoglycemic at night because they were wearing their continuous glucose monitor. What an easy fix.
Right? Yeah.
Yeah. So that was a really good find. I love having those continuous. So that's usually what I recommend. Hey, your blood sugar's high. Let's make sure, what is it doing most of the time? So we want that 2 hour, your blood sugar is going to go high when you first eat. So I don't worry about what their blood sugar is immediately after eating. But what's that 2 hour postprandial? And what's the first thing in the morning? What's your fasting blood sugar in the morning when you first wake up? And really, ideally, before you get out of bed, because that cortisol surge is really going to happen.
I was going to say, yeah, because you are going to get a bit of a blood sugar spike first thing in the morning. You have to, cortisol spike.
And it's interesting if you look at Mikhail Blagosconi's research. He's the big rapamycin researcher. If you look at his research, he has this lovely article on benevolent hyperglycemia that I love. And especially if we're talking about peptides at any point, there's a lot of these peptides that are metabolism regulators that when you first start using them will actually show an increase in blood sugar. And it's not because you have insulin resistance, it's because your cells are choosing to burn fat. And so you'll get this increase in blood sugar that's a response, not it's in response to choosing a different fuel source. Right.
Those peptides.
Mata-C will do it. Dihexa sometimes will do it. And so I tell people just wait 6 months before you recheck.
Oh, that's so interesting.
It's very interesting.
What are you seeing with semaglutide?
So I haven't seen it be as effective. I'm kind of excited about the new GIP-GLP combo that's just come out.
Epitide? And it's got a funny name, Moonal or
Mounjaro.
Mounjaro, that's it.
Yeah, I'm kind of excited about this because I think we're really going to really attack that incretin effect. It's a little bit confusing because the GIP, it's got some back and forth confusing effects when you're looking at how it works. I think it's because it works in different ways in different cells. So when you're looking at the research, you're going to see that GIP works differently depending on where it's working. So now we're introducing a load of GIP to these patients, and the pharmaceutically supervised or supported or promoted research shows significant drops in A1C and significant improvement in weight loss versus GLPs alone. So I think that's going to be a promising candidate. I have a patient right now, his A1C has been as high as 11.
Yeah.
He is down to about 8.
After how long?
Anyway, it's not great, but it's still better than it was. And so we've just switched him from a GLP-1 to the tirzepatide, which I'm excited for him to try. So the jury's still out. I'll let you know what I find out. I'm going to be following lots of labs on him and see what else is affected, kidney function, et cetera.
Yeah, no, I think that'll be really, because I would say with the semaglutide, and it's, again, when we first started talking about it, it was like, oh my God, it's this amazing thing. What I've seen, and I'm not seeing it as a doctor, I'm seeing it as like in my Facebook community, because I have so many people there and so many people have been using semaglutide, including me. And what I'm seeing is it works really well for some people from a fat loss perspective. And it doesn't work for other people.
Yes, it doesn't work at all.
It's like some people, it makes them really sick to their stomach, and it doesn't seem to move the needle for them for fat loss. And I've heard another practitioner say he thought that maybe if someone's very leptin resistant, the semaglutide wouldn't hit the mark for them. And I don't know if tirzepatide will be different because it's slightly different pathways. But definitely there's certain subset of people that just A, don't tolerate it, and B, they're so depressed because they hear all the other people saying, oh, well, I lost 15 pounds, I lost 20 pounds, I lost 30 pounds. And they're like, I just barf and I haven't lost a pound. I feel terrible, or they feel very tired. So it is interesting with these medications that they come out and the research looks really, really good, but still when you see it on the ground, you're still seeing different things than they're reporting in their studies.
Exactly. Yeah. I do think we have to watch with those patients. We can go back and circle back to what we were talking about. We do have to watch kidney function with the semaglutide patients. Because it suppresses appetite, it also suppresses thirst.
Oh, interesting.
So you have to counsel them ahead of time. Please, please, please drink lots and lots of water, because they'll end up getting dehydrated because they're not taking enough protein. They're not getting enough water. And so these patients will end up with some it appears to be kidney problems that are, it's usually azotemia. It's pre-renal azotemia that's reversible when you hydrate them well and get them to get a little bit more protein in their diet. They do better.
Yeah, well, that's such a great point, because I do think that the risk of these peptides, because they suppress appetite so effectively, is malnutrition. Like,
yes.
Like they don't want to eat that much, and then they start to go for the wrong foods, and then they're like, well, I'm losing weight anyway, so what difference does it make? I can have a little bit of pasta. It's like, yeah, so you're starving your body of nutrients, actually.
Yes. Yeah, that's why in those patients, we use a bioimpedance analysis machine.
Yeah.
So anybody we put on semaglutide, we bring them back monthly, and we get their muscle mass, their fat mass, whether they're hydrated well. It just tells on them. So I can say, hey, look, you're losing muscle. So all of your weight loss was all the good stuff. Oh. That doesn't usually happen with semaglutide. It's usually at least half and half muscle fat. Usually it's more fat loss. So
yeah, I think because it has an affinity for skeletal muscle insulin sensitivity, right? So, I mean, to me, the opportunity with semaglutide, and probably with tirzepatide, will be the same. The opportunity is actually to improve your eating habits, to improve your exercise habits, to make the most of this window where you can build lean mass, eat a better diet, and get all those benefits, so that you're not dependent on it for all eternity.
And, we have great reports. I have patients who've lost 20 pounds, a guy in his 70s who lost 20 pounds and gained, I think he lost 20 pounds of fat and gained 10 pounds of muscle in his 70s. Now, he also began and he's being consistent, a resistance training program.
I love it.
So, yeah.
That's amazing. That's exactly what we want to do for anti-aging, right? And it gets talked about so little. Like we talk about, manage your inflammation, manage your fat mass, manage your brain, but build muscle.
Yes. Oh, sorry. I confess. He was also on testosterone. So he was on semaglutide's testosterone.
That's interesting. Okay. Interesting. You did both. Okay. Fasting blood sugar. What's next?
Okay, so if we go down that list and we're talking about, if we're looking at a complete metabolic panel, I'm just doing it in my brain now. So the two markers of aging and disease that I think are really helpful is albumin and alkaline phosphatase. And I love those two because study after study after study shows if your albumin is greater than 4.5 and your alkaline phosphatase is less than 60, your chances of having a good outcome from that illness, whether it be the recent virus, whether it be cancer, whether it be pneumonia, whatever your heart disease, an albumin greater than 4.5 and a alk phos less than 60 is beneficial in your recovery from and sustaining of that illness. So I call them markers of aging and disease.
So we want them to be greater than 4.5 and alkaline phosphatase to be greater than 60?
Less than 60.
Oh, less than 60. Okay. So we want alkaline phosphatase to be less than 60 and albumin to be greater than 4.5. And that sets us up for better outcomes if we come across a challenge.
Yes. Both of those go in the opposite direction with aging. We know that albumin goes down with aging, and we know that alkaline phosphatase goes up with aging. And so these are great markers of aging. If I monitor someone over time and I see that their alk phos is going up, or I see that their albumin is going up, then I know that this is a patient who's aging faster than I want them to.
I love that.
And then the other thing that's interesting about alkaline phosphatase, especially if we're talking about intestinal alkaline phosphatase, it will dissolve the, I think it's the lipid A moiety of the lipopolysaccharides. So remember, lipopolysaccharides are the cell surface of bacteria that may be in the intestines, the pathogenic bacteria. And alkaline.
Sorry. Keep going. Sorry. Carry on.
Alkaline.
Back, guys, I just got to take care of this wasp. Go ahead.
Oh, no. alkaline phosphatase goes up in response to the presence of those. So if you're looking at your regular complete metabolic panel and you see that your alkaline phosphatase is generally normal, and all of a sudden you see an increase, or over time you see an increase, one of the things to think about is what's happening in my intestines. Do I have some dysbiosis that's going on? Is there a problem with zonulin? Have I broken down my mucosal layer? Am I having trouble with, am I getting enough fiber in my diet? So all those things you need to begin to think about. That's not the end all be all to tell you, yes, you have a disease there, but it means it refocuses our vision, the elevated alkaline phosphatase, to say, oh, is this possibly related to that? We also know there's a version that goes up, that's a bone alkaline phosphatase that can go up with fractures, but also goes up with cancer of the bone. So just beware, there are other reasons why alkaline phosphatase will go up. But probably the most common reason is something intestinal dysbiosis. So it's something that you should think about in seeing an elevated alk phos. So
just a quick question. So when you see an elevated alk phos, though, you don't know if it's from the gut or the bone. They don't do that in the lab. It's just now it's pointing your attention to, okay, let's investigate dysbiosis of some kind in the gut, or could there be something going on in the bone? Could it be, you mentioned bone cancer, but could it be a situation where osteoporosis is at play, or does that not show up in the alkaline phosphatase?
It could, especially if there's something that's rapidly depleting. So hyperparathyroidism, I'm trying to think of what else would rapidly cause you a heavy load of steroids. Let's say you have lupus and you have a flare and you have to take a heavy dose. You probably would see your alkaline phosphatase go up.
Okay.
You know, and you can either ask the patient, are you having symptoms, intestinal symptoms? Yeah. Or you can do a specific blood test that will break it down for you into the various kinds of alkaline phosphatase, and it'll give you a more specific, they're bone derived or intestinal derived or other. And so you can get a more specific look, but you can also ask the patient. So I like to look at the patient.
Dysbiosis, I mean, so many people, like you'd be hard pressed not to find someone who couldn't do a little work on their gut and benefit from it these days.
Yes, for sure. Yeah, absolutely. And then I'm going to pair that information with their liver enzymes, the other liver enzymes. So we know that alkaline phosphatase is one of the liver enzymes, or can be a measure of liver function. So we also are going to pair that with your liver enzymes. And so the normal ranges for those typically are less than 40, but the research is consistent with those optimally being less than 25.
Okay.
So if I'm seeing a patient who has a liver enzyme greater than 25, I'm talking to them about their over-the-counter pain medicine use. I'm talking about their alcohol intake. We're talking about dysbiosis. So let's say I see a high alk phos and a slightly high liver enzyme. Now we're talking about what's going on with your intestines, what's happening that you are, is there some sort of, I'm also going to look at an SHBG. I'm also going to other liver enzyme things. Is this specifically liver, or are we talking about something that's happening in intestine in general? What's their bilirubin? Is their bilirubin elevated? So it's trying to put together a whole picture, because none of these is specific enough to say, unfortunately, and I feel like all the time patients are kind of expecting us to have a blood test that is the answer to the problem, and that doesn't exist. So it's really it's sort of like when you do a 1,000-piece puzzle and you're putting together each little piece, and you're like, oh, that looks like a face. And you find out, no, it's actually the back of someone else's head.
Yeah. Yeah.
And so it's putting these pieces together. So having tighter ranges, more than what the lab shows, first of all, it allows you to pick things up earlier than before they become a disease.
Yeah. For sure.
And second, it allows us to put more pieces into the puzzle to say, oh, look at this. This is how this piece fits here. Maybe this is what we're looking at. And it directs us into a direction to look for what the root of the patient's problem is.
Yeah, no, I love this information. This is great. And it's actually, and I guess we're going to get to cholesterol shortly.
Yes.
Soon. And it's the conversation we were having earlier, where you've got your HDL, your LDL, your total cholesterol, but LDL has been painted with this horrible brush of being the bad cholesterol. And And in and of itself, like an elevated LDL could tie back to the thyroid. It could tie back to systemic inflammation. It could, and it's not bad. We kind of need it. It's just doing its job, guys. It's just doing its job. So anyway, I didn't just not to.
No, I think that's a great segue. Let's go there. I completely agree with you. There was a study that just came out about total cholesterol, that there probably is a higher range. We need to kind of be keeping people in a higher range of total cholesterol. So even that 220, 250 is probably our best range to see people keep their total cholesterol. So that's kind of flies in the face of most cardiologists, at least around here. And so it's a little bit of a challenge to figure out what we need to do, because the information is coming from lots of different sources. Some of it is, what's the source of your information? You know, was it pharmaceutical funded? The trouble is, most research has to have some funding. So where are you going to get it? Who has the deepest pockets?
Yeah.
So that's a trouble. And I don't know the solution to it except to do the very best we can. Yeah. So I think that we just have to realize that cholesterol is so important. In your mitochondria, cholesterol is converted to pregnenolone. Pregnenolone is one of the most important brain calming hormones that we have. So for protecting your neurons from damage, I think pregnenolone is so important. Not only that, it's the precursor to all the other hormones. Mm-hmm. So if you don't have enough cholesterol, you can't make all the hormones.
Yeah. Yeah.
If you don't have enough cholesterol, you can't protect yourself from illness, because making cholesterol is one of the ways our body takes care of bacteria and viruses and parasites. It surrounds them with a little fat layer and then sends that fat layer off to be processed by the liver. So an elevation like you're suggesting of the LDL cholesterol, I like to call it lousy cholesterol, because it goes up when you feel lousy.
Yeah. Yeah. Okay.
And so your LDL cholesterol will be a little bit higher. For example, with the most recent virus we've had, it will be higher in the face of a lot of other illnesses. And so it's really a beacon more than it is a problem to be attacked. Yeah. So keep that in mind as you're discussing what your treatment is. And I'm not against using statins. There certainly are places for it. And I have used them especially in the most recent virus that we've suffered, but in some patients. But I think we need to realize that lousy cholesterol is a beacon and not it's not a problem to be attacked. We need to look for, why is their LDL high and what can we do about that? And then we'll just see the LDL follow. It's just going to tell us, yes, you've done a good job. This is the right thing. Right. So if we treat the LDL itself, we're going to run into problems with all the other things we already talked about: inability to fight off, inability to make cells, inability to make hormones. Yeah.
And also, what about looking, and I don't know your opinion on this, looking at the LDL breakdown itself. So what is, because LDL it really is it 4 different populations of, you've got fluffy LDL, you've got hard little guys, you've got the oxidized little guys, you've got, so like at what point do you start to dig into those fractions to understand what's this LDL made of? Because, I read a study quite a long time ago now, and I can't remember what type of study it was, but they were talking about how in elderly populations, they had found that people with the lowest cholesterol values were more prone to depression and dementia than people who had what would be considered higher levels of cholesterol. And so, talk about confusing the population. Like, on the one hand, you've got a faction of people saying, we need to wipe out your cholesterol or you're going to die of a heart attack. And on the other side, they're like, yeah, well, if you don't have enough cholesterol, you're just going to lose your mind. And you can imagine a person sitting there going, I don't know what to do.
Sorry, your muscles hurt, and so you don't feel like exercising.
Exactly.
Yeah.
Exactly.
It's a real problem for sure. And and so for us as integrative advanced medicine practitioners, we really need to find someone that we can partner with to help make those decisions. And we also need to be doing things to treat this. It's not a matter of not. So one of the tests I do is I'll back up in a second and answer your question about the when do you get into them. One of the tests I do is a CT coronary calcium score.
Yes, I keep hearing about this.
I just think it's worth it. If I'm seeing, if this is a patient where I would have in the past, because I come from allopathic medicine, I was a family doctor for many years before I went into this advanced medicine. If it's a patient who I would have in the past done given them a statin and just sent them on their way, that patient now I'll do a coronary calcium score. And if it comes back 0, yay, I'm very reassured. It's not perfect. Again, no test is perfect.
Yeah.
And I'll have that conversation with the patient. I have the luxury of having that conversation because of the kind of medicine that I practice and the time that I allow myself. But that's a test that's really easy to do. It gives you good information. If they come back at 1200, they're going to the cardiologist.
Yeah.
We're doing maybe a nuclear test, probably a cath. We're going to send them immediately. So that's an easy patient. The harder patients are like, what if they're 80 and they come back with a score of 250 or 300? Now, what do you do?
Mm-hmm.
That's a little bit tougher question. I'm going to aggressively treat them and retest quickly. I'm not going to let them go 6 months like I would a 30-year-old or a 50-year-old. I'm going to do a little bit more aggressive, more testing.
So what would you do for that person? Would you be putting them on a statin at that point, or would you? You have other tools in your toolkit. I love that. Okay.
So when I first started out, I learned about the NMR testing a long time ago, back when I was regular family medicine. And I just never felt like it changed what I was going to do for the patient. So that whole panel that I used to get was really interesting. Part of that's because I had one tool in my toolbox at the time. I was like, why would I do that test? It's not going to change anything. But the things that I finally pared it down to that really seem to matter, I do a Lp(a).
Yeah.
Because I want to know their genetic predisposition.
Yeah.
I do an ApoB. So ApoB is like it is the address label that goes on the outside of the package of cholesterol. So your cholesterol travels in your bloodstream in packages. Those packages have an address label on the outside that tells them where to go. This ApoB says, go to the arteries and make plaques. I know that's very simplistic view of how it is, but it's a really easy way to think about it.
Yeah.
And so if you have a lot of ApoB that's sending your cholesterol packages to your arteries to make plaques, that's a problem, or to bind up infection or whatever. You're going to see that with your ApoB as well. But if you're in any inflammation, that's when you're going to see that ApoB go up. Mm-hmm. If your ApoA is higher, and I also don't usually test ApoA, but if your ApoA is high, then that's if that's the address label, it's going to send those packages to your liver to be processed out through the stool. Hallelujah. It's a good measure, kind of goes hand in hand with your HDL, which is why I don't test it, because I follow HDL instead.
Okay.
Again, not perfect. It's just a way to think about it. And so for me, I got to the point at one point where I was ordering 30 or 40 tests on every patient. And I finally said, I don't have time to go through all these labs. Yeah. So my shrunken down version is lipid panel, ApoB, Lp(a).
Yeah.
And then if they have other things, if they have a significant family history, if they have, I'm going to do a lot of other things. I'm going to do a myoglobin. I'm going to do a fibrinogen. I'm going to do a LPPLA2. I'm going to do a F2 isoprostane. All those things we're going to check if we're really checking them and following them. But if I can get them back and I can treat them and get them where they're looking normal, then or normalish, then I'm going to not worry about it. If I get their 300 coronary calcium score back, I'm probably going to be checking all those labs.
Yeah. So you're going to dig deeper. That's your cue. So going to the VLDL, oxidized VLDL, that degree of lipid testing, do you do that right off the bat? Like, do you think people should be looking at that? Or do you think that it's overkill? Or is there a situation when you want to do that kind of testing?
I like the oxidized LDL because it's easily available. I can get it. We use a Boston Heart, and I can get that easily from them. So that I will do more often.
Yeah.
It's probably not in my initial screen unless I think, so if I'm seeing a patient, when would I use that? It's going to be in my initial screen if they have Lyme, mold exposure, some sort of other toxicity that I'm looking for. If this is a generally healthy person, unless I think they're overtraining, I'm probably not going to do an ox LDL off the bat.
Okay.
In most patients, I'll end up getting that Genova NutriVal because it's such a great overall health screener, and it's in that. So I probably won't get it on my initial screening of the patient. I'll probably get it on a later, or I'll do it in the NutriVal.
Yeah, the more advanced testing kind of thing.
Yes.
The nutrients and that kind of thing.
Exactly.
I love it. So can we talk also a little bit about LDL and inflammation, or as a sign of inflammation, or a sign of, as you were just saying a minute ago, infections? Like, how do people, and I'm guessing it's going to depend on other markers that you're seeing that are pointing to that as well. Like maybe a CRP is high, or
yes.
other inflammatory markers. Is that?
So CRP is something else I'm going to probably do on a screener, partly because it's part of my, I have an algorithm I use to measure the patient's age that's just cheap, but it's a CRP, CBC, and CMP, and various factors from those, and based on Dr. Morgan Levine's research.
Yeah.
So I do and so CRP is part of that test. So CRP is a general marker of tumor necrosis factor alpha and IL-6.
Yeah.
So I know if their CRP is high, their TNF alpha and their IL-6 are also high. So then we're talking about some sort of great inflammatory problem going on. Again, my goal for a CRP is less than 1.
Yeah.
If their CRP is anything greater than 1, I'm concerned about what's going on with them.
Yeah.
We have to figure out. Now, I have a few patients who I just know their CRP is 2. That's where it is. And if it goes up to 3 or 4, then I get concerned. But their 2 is where they live. That's where their body is. I'm not saying I don't get concerned and figure out why, but it might be a patient who has lupus. It might be a patient who has Lyme disease. It might be all kinds of reasons why their CRP might hover higher than I want it to.
What about an athlete? Like someone who just does crazy exercise, like, like a CrossFit person, or?
Yes. So you would expect for their overtraining to definitely cause that. Absolutely.
Yeah.
And so that LDL is going to go up in response to that to try to counteract the elevation in their TNF alpha and their IL-6. So you're going to see that happen. And yeah, so you're going to put together all these pieces, CRP, LDL, you're going to look at their monocytes in their CBC, a monocyte level greater than 10, greater than 9. It's hard to find one that's that low. So most of them, I can see most patients that are, I can keep them less than 10, but a monocyte level that's high, you're going to be concerned about them having that. So then you're also talking about chronic illnesses like CMV, like EBV. Do they have a chronic viral infection that's kind of distracting their immune system from doing its daily job?
Yeah, that's crazy. I love it. And I see, guys, LDL, not bad. I mean, not bad on its own. It needs to be, it needs a new name. Just needs.
Yeah.
Okay. So we've done cholesterol. Are we looking at triglycerides at all in a meaningful way? That's got to be part of your, because that's easy. Like, here, I mean, the problem here is I've spoken to people, and here being in Canada, like they have to fight with their doctors to get them to look at anything more than TSH. And they have to fight with their, like and I've heard it also out of certain people in the US. And I think it's part of it is because your insurance company only allows you to go to certain doctors, and they have their own limitations, or whether it's their mindset or whatever the insurance company will pay for. But, triglycerides is something that anybody can get.
Yes.
It's standard. And do you look to triglycerides do you see them as also feeding into other pieces of the puzzle in different ways?
Absolutely. So it's part of my metabolic health thought process. So I think of that as part of metabolic health. And I'll include in that an A1C, the fasting glucose we mentioned before, a fasting insulin.
Yeah. I
love adiponectin. It's my pet. I love adiponectin. I don't know why. It's so cool. I just love it. It's actually, I could go on and on. I'm sorry. I'm going to leave. We'll leave that for another.
No, but let's tell people what adiponectin is and why you love it. I mean, we still have some time. We're good.
It's a signal to your other cells that they should choose to burn fat.
Yeah, we love this guy, guys. I mean, we want this.
Yes. And it's so cool because it's 3 different little pieces of adiponectin. They have to be together in a trio, and they're joined together at a cysteine moiety. The 3 are joined together by this cysteine, which is an amino acid that's in this peptide. So it's a peptide. I mean, adiponectin is a peptide.
Okay.
In order for them to be joined together, the cysteine has to bond together in this sulfur bind. Sugar from your diet comes in and blocks that cysteine from binding. So now the trio can't bind together. Therefore, they can't leave the cell. So the signal to burn fat can't get out to tell the other cells. The cells.
Yeah.
It's really smart. It's a brilliant design, right? Brilliant design. And so because there's so much sugar around, you want to block the fat burning mechanism. And so you increase you have all this adiponectin laying around, but you don't allow it to become its full mature self and then be released to do its work in other cells, which is great. So it can be because you have low sulfur. There can be, if there's a problem with, there's a lot of metabolic problems that can occur with not having enough thiols in your body. That can be a whole other conversation. But the biggest reason is because of dietary sugar. And so this is your body's protective mechanism. So it kind of tells on you that you're taking in too much sugar in your diet, which is
your adiponectin is low.
Yes, adiponectin is low. Exactly. And we're talking about a blood level of adiponectin being low. And the measured adiponectin is that trio of the 3 peptides to join together at their cysteine bonds. And so you're going to see, I like to see an adiponectin be greater than 15.
Yeah.
And a lot of my patients hang around 10. So if you get an adiponectin that's less than 15 and an insulin that's greater than 10 and an A1C that's greater than 5.4, now we're talking about someone who has some insulin resistance or some impaired fasting glucose. So we're talking about a cellular metabolic dysfunction. Mm-hmm. And no wonder the patient can't burn fat, can't lose weight, because they are either telling their cells or by their metabolic dysfunction telling their cells to leave the fat where it is, don't go through lipolysis and break down, use sugar as a fuel source. And now we're having problems with patients having difficulty losing weight.
Right. And would be also the disaster of people who get confused and eat fat and sugar.
Mm-hmm.
And that's when fat makes you fat.
Yep. So then we get lipogenesis and creation of more fat stores rather than lipolysis and breakdown.
Yeah, without the ability to use them and break them down.
Yes.
Yeah. So that, big bowl of rice with fatty stuff on it, or your poutine, bad idea.
In theory, it's a good idea. If you have those bowls where it starts with the protein at the top and then it goes to the vegetables and then you eat your rice, in theory, it's a good idea as long as you eat them one at a time in that order.
Yeah. Yeah. Otherwise you pig out on because theoretically you should be filling up on the protein, finishing off with the vegetables, a little bit of healthy fat. And then if there's room, and that should be the order, right? Then if there's room, you have that carb. But unfortunately, our primitive brain dives for the carb.
There's always room for the rice.
Right?
I confess, I had the most amazing brisket mac and cheese last night.
Oh my God, you did not.
Oh, it was delicious.
That's why you kind of have to do what you have to do.
Yeah, this is not so, I never eat mac and cheese. It was amazing.
It's definitely one of that mac and cheese is one of the, did you hear that Kraft Dinner is changing its name from macaroni and cheese to mac and cheese?
Really?
Yeah, I just read that today. I mean, this is a stupid fact, guys. I know the people listening to the podcast are going, and I needed to know this why. I'm not exception to every rule. Okay, so we've done triglycerides. We've talked about adiponectin, your pet peptide. Are there any other labs or blood markers you wanted to talk about today?
You know, I'm super curious if you would share what you use for your genetic testing.
Oh, yeah, sure. I'd be happy to. So, I mean, the genetic test that I'm very loyal to it. And yet every once in a while, it's not the cheapest genetic test. So I'll try and go to someone else. And then I keep coming back to this one. And in part because of how they present the information to the patient, well, to the client in my case, and to the practitioner to help me to interpret it properly. And it's the Apiron test. And I was trained, I did training with them a couple of years ago. And I find that, the tricky thing with genetics, and I think maybe it's a little bit like how you're talking about blood work, but even more so. And that is that it's not prescriptive, right? Just because what we're talking about when we look at your genetics is we're talking about a predisposition. And we're also talking about a predisposition based on what we know right now. And genetics more than anything, and I mean, everything is a little bit like this, but genetics a lot like this, is that there are so many genes that we don't know what they do that are working in the background. And if there's one thing we know about the human body is that it has a lot of redundancy built in as safety mechanisms.
Yes.
And I feel like, and they teach this very well in this course, you've got to watch your language when you talk to someone about what their genetic report is showing, because you actually wouldn't say to someone, oh, you have this gene that is going to cause you to do this. You're actually going to ask a question and say, well, some people have genes that show that maybe they have trouble feeling full when they eat. And in some cases, that is the case. But you're not going to say to someone, oh, look, you've got this messed up satiety gene. I'll bet you can eat till the cows come home. Because sometimes the person's like, actually, no, I'm good. I'm really good on portion control. So you're going to want to ask the person, well, how do you do with food, or how do you do with sugar? There are certain genes that, like, I carry this one variant of a gene. And the other thing that they excise out of your language through this course is mutations.
Yes.
This is not about mutations. This is about what variation, what variant of a gene do you have, so that if you understand it and we see it reflected in your life, how do we kind of biohack around it? How do we change your behavior? And so this one gene they've nicknamed the cookie jar gene, which is a gene that, and I think it's TAS2R93, like it's got a whole list of letters that I never remember. But the cookie jar gene is a gene that for people who have it and who are homozygous, I think it's A for this gene, when we start eating sugar, it literally flips a switch in our head and we can't stop.
Mm.
If you don't start, you're good. But if you start, stopping is really hard. And I know that.
Does that feel true for you?
Absolutely. Like if I start eating like gummy bears, or which gummy bears are you've got the mac and cheese and brisket, I've got the gummy bears. So, gummy bears or like certain cookies and stuff like that. I have to exercise a huge amount of willpower to stop myself. And whereas other people, they're like, yeah, they can have a couple and they walk away. They're fine. Yeah. And so some people, but I have come across a couple of people who have are homozygous on this gene, and you say to them, how do you do with sugar? And they're like, no, I don't care for it much. And so it's, you wonder, like, did they adapt and figure out, and usually they're people that are quite lean, they have a really healthy diet, the whole 9 yards. Did they at some point, as they, in their life, figure out, yeah, that sugar thing doesn't work for me, and they just don't go there? Or is there something else at play that we don't really know about that's coming in and overriding the effect of this cookie jar gene? But for some people, and for me in particular, I know if I don't want to eat sugar, then I need to stay away from it, because once I start, it's game over. So in a way, it's very informative, right? Because it takes, for some people, they carry a lot of shame around these things, especially people that are very overweight, for example. And so helping them to understand, oh, you know, maybe they have a shortage of dopamine receptors, or their pathway for breaking down dopamine is very upregulated. And then so helping them to understand what's going on in the background and strategies and ways for them to help themselves to compensate for that can be really powerful. So
yes.
I
love that. I love that you made that very clear, because I think there's only a few, you probably know the number better than me. Is it something like 40 diseases that have a direct link with a gene, with a genetic variant?
Yeah. And
other
talk about those, right? Because that's like in the realm of disease. We have geneticists talk about that.
Yes. And I think what's so interesting, I've been fascinated to follow the research that's ongoing with epigenetics.
Yes. Yes.
So fascinating. And I think the more we know, the less we know. I think this is such an evolving, it's so exciting to be part of it and to watch what's going on. The things that they can tell you based on your epigenetic testing. I think that's really fascinating. So do you do that now? Do you do any of the epigenetic testing, like aging?
The aging, yeah, I do. I use the True Diagnostic DNA methylation test that gives you your biological age versus your chronological age. I find that really interesting. I think that's
interesting.
And it's more interesting now, of course, that we believe that we have strategies that can help people to change, right? So it would have been less interesting when those tests first came out. And the belief was, well, there's nothing we can do. So why would I tell someone that they're aging twice as fast as time is passing by if it's just setting them up to be depressed and older than they are, right? So whereas now, you know, understanding that your behaviors, your lifestyle, and certain supplements or certain peptides, like the bioregulator peptides, are, you know, to the people who've been studying them for a long time, are nothing more than very powerful epigenetic switches that they can flip genes on and off. So now that we have a toolkit, and so much of it is lifestyle, which I also find, to me, no, you don't have to go spend like $1 gajillion. Maybe you could just stop, you know, staying up till 3 o'clock in the morning, eating candy. And that will slow down your aging in and of. If you can get rid of that habit, we can start to slow things down a little bit.
Well, it's interesting, Natalie. I used to poo-poo people wearing the wearables, because I thought, well, how is that going to make a difference? Well, it's so interesting, because I can have a conversation with a patient over and over and over again about how they need to get more hours of sleep. But if their wearable tells them they need to get more hours of sleep, they will start getting more hours of sleep.
Absolutely. Well, and they see it reflected, right?
They come back and they say, do you know, I started sleeping 3 more hours a night, and it's amazing how much better I feel. And you're like, I know we had this conversation.
Or got the CGM on the back of their arm, and they're like, you know, I started sleeping and all of a sudden my blood glucose seems to be lower. Oh, man.
Yes.
Sitting there going, yeah. But you're cheering them on, right? Because
yes.
And I don't blame people for this at all. Honestly, I think that if it's as simple as wearing, whether it's an Oura ring or a BioStrap, whatever your wearable of choice is, if it's as simple as helping people to connect the dots between their behavior and an outcome, that, and on top of that, maybe that they feel, which is, you know, that's nirvana, right? Something
Yes.
is one thing, but then if they feel different, you know, we now become so much more invested in that outcome. I think that's just where the power lies. And in many ways, I feel like it puts the power back into the person's hands.
Absolutely.
Right. And
it's the best to watch them come in so excited. Look at my HRV. It went from this to this, and I did this intervention. So exciting. So yay, bring them on. I love them now. Yep. We have a sleep number bed. I have a funny story. We have a sleep number bed and we both wear Oura rings. And I kept finding that my sleep number bed was measuring about 30 to 45 minutes longer sleep than my Oura ring was measuring. I thought, this is so strange. It's because my husband rolls over onto my side of the bed in the morning and sleeps in an extra 30 to 45 minutes.
That's hilarious. What's a sleep number bed? I've never heard of that.
It's air filled and you can change the setting on the, it's so comfortable. Oh my gosh, I love it.
I just bought an expensive mattress. I can't hear about a new mattress.
Okay. I do love my sleep number bed, but you change the setting on the how
Firm
dense it is, how firm it is. Yes. Based on how you sleep. And so you find your sleep number and that's what your sleep number is. And it changes whether you're sleeping on your side or sleeping on your back. It will change the pressure points. It's great. I love my sleep number bed, but it also measures, it gives you a very simple
HRV.
It does give you a very simple HRV.
Wow. And so is this something you add to your mattress or is this a mattress you buy?
Mattress.
Okay. No, I just got a really good, I've got an Essentia, which I love. So, and my husband, it took him a little while to recover from that purchase. Won't be bringing up any other kind of mattress for a little while.
Mm-hmm. That's so important though, to get good sleep. You have to have the right mattress.
Totally. No, I'm with you. And the nice thing about the one we got, the Essentia, I actually had Jack Delaccio on the podcast. It'll either have come out just before yours or just after because he was recent. And it is remarkable how big an impact that mattress has on and we don't think about it, right? We keep the same mattress for 20 years, 25 years, and you spend so much of your life on that mattress. And it has such a huge impact on your health, like from the off-gassing of the fire retardant stuff they spray on it, like you were talking about earlier for thyroid, to, how it gets all saggy. Like our old mattress, I was feeling like I was rolling down the hill. I was getting
Oh, yes, so bad.
Kind of hanging on to the edge of the bed. So getting that sorted out and I think it's the simple things first. Yeah. Before we get to the fancy stuff. And I think part of that is what you were talking about today. And these are, in many cases, these are basic lab metrics that you can get from a basic lab blood panel that is going to give you, if it's looked at by the right person in the right way, and they're not just looking at one number, it can give you so much information about where you're at with your health.
Right. Which intestinal health testing do you do?
So I don't use a ton of it right now. So personally, I mean, I don't use a ton of it right now because I'm not doing that kind of work with clients. So I very often will partner with a physician and I let them do some of that more advanced testing.
Yeah, we do. I flip back and forth. I like the Vibrant America test. I like the Genova test. Genova's covered by Medicare, so I probably will do that. Yeah, with most of my Medicare patients. I don't have that many anymore, but the patients I do have that have Medicare, I'll use that. Genova. I like, they give different information. So Genova, I think the zonulin is an add-on of something, $50 or something add-on. The Vibrant, I think, includes it automatically.
Yeah. I do have a lab in Canada that will, and actually they work in the US as well, that do just a separate zonulin test. That I will for my clients. Because, one of my pet peeves is people that do food sensitivity testing and they haven't tested to see if the gut's permeable.
Yes.
You're going to show up, that's when you get panicky clients who are like, oh my God, I can eat 4 foods. My life is over. And it's like, okay, well, let's just see if you have got permeability first, because if you do, let's put that away for a little while and do some work.
Yeah, there's some things we can do, including some peptides.
Yes. Yeah. We have 5 minutes left.
Okay.
Let's give people a crash course on some of the peptides. I think some people, you know what? Everybody knows BPC 157 is going to help with gut permeability, but let's talk about the one that is starting to get a bit more airplay, and talk about that one, because I think it's a little less known and it's pretty exciting.
It's my unsung hero right now in a lot of my patients. It's been fun to use. So Lorazepam, AT1001, I believe is its chemical name. Chemical name may not be accurate, but it's number name. And think about Lorazepam as, let's simple down how this intestinal wall works. So if you think about a starter home neighborhood where newly married people will move into their starter home, and it's just house after house after house after house, and there's 10 feet between each house, and those have a fence, a large, tall wooden fence in between each house. And you have a little dog in your backyard and maybe some kids. That's what your intestinal wall looks like, is the row of houses with the fence in between. The fence in between is the tight junctions that keep things out that aren't supposed to be in there unless you have a key to the lock, or unless you can get in through the front door of the house. So let's say something comes up. Stress can be a trigger for this. Let's say an infection. Let's say you have a colonoscopy and you get the prep before your colonoscopy. Let's say you have antibiotics for a urinary tract infection, for example, or a sinus infection. Those sort of things are going to raise a protein called zonulin. Zonulin then goes and breaks down the intestinal barrier. The intention is, zonulin's on purpose. It's not a bad, it's like LDL. It's not bad. It's intentional. Its goal is to open up the way for the immune system to come out and help fight off this infection that's present in the intestinal lumen. Unfortunately, it allows a lot of intestinal and a lot of things to get into the body. And then we run into inflammation and all kinds of other problems. So if we can keep that zonulin from, especially in the case where there isn't an active infection, let's say there's a significant stressor for whatever reason, you just found out that your, house was burned down or something terrible. What we want to do is block that zonulin from breaking down the intestinal barriers. So we also know that gluten can be a trigger for zonulin release. And so this is one of the reasons why a gluten-free diet is really helpful no matter what your disease state is. There can be lots of benefits. Even if you don't actually have celiac disease, you can avoid gluten in your diet, blah, blah, blah. So if we find out that your zonulin is high, one of the things we can use is this amazing peptide called zonulin. It's called Lorazepam, that blocks the zonulin and keeps it from breaking down those the barriers between the intestinal epithelial cells. The sweet spot dose, it comes in several different doses. It usually comes in a 0.5 and a 1. And it seems like the best effect is actually at the 1. This is not a more is better peptide.
Yeah.
If you do actually have celiac disease, and most of the research with this is in patients with celiac disease, probably because that's where they'll get it approved quickly, because more rare diseases, drugs can be approved more quickly for more rare diseases. So if you have celiac disease, we'll probably get it approved for that. So just be aware, it's probably going to be available as a pharmaceutical in the not too distant future. But right now it's available compounded through lots of different places and through some labs as well.
Yeah.
Research labs. And this is given 3 times a day before meals, ideally 15 or 20 minutes before you eat. And then I do have some patients who do really well if they just take it before a meal that they know where they're going to have gluten, or if they take it once a day. This can also be helpful. I have some patients, it's not inexpensive. It's a peptide, so it's not going to be inexpensive. And so some people can get away with just using it on days when they know they're going to need it, or just using it on days when they, or just using it once a day instead of 3 times a day.
So for once a day, would it make sense at night? Basically, you're done eating, your body's repairing as you sleep at night. I wonder if that nighttime dose might be just what the body needs to kind of repair the damage from the day? Or do you think it's better off in the morning to prepare the body for the day?
I think it's better as soon as you can. This is why the original dosing was done before meals, because the goal is to block zonulin from even being released in the first place.
Right.
It doesn't do any mucosal repair except for removing the zonulin.
Yeah.
It doesn't do mucosal repair. So you're going to need to do glutamine. You're going to need to do marshmallow. You're going to need to do all the things that you would normally do for barrier mucosal repair, butyrate, fiber, all those things. But but what you want to do is take this before your exposure, which is why in some cases we think it would work best if you just take it 20 minutes before breakfast every morning and then go about your day.
Well, and that's interesting because some of the smart formulas we're seeing out there, and I was just telling you earlier about this new, relatively new company out of Australia called Level Up Health. And what they've done is they've smartly taken BPC 157 and paired it with the liraglutide and the tributyrin and the glutamine and the zinc carnosine. So he's really,
Beautiful.
And I think his next iteration is going to have the KPV in there as well. So creating this kind of holistic formula that will block the zonulin, will help to repair the damage. Like it's just,
yes,
it's a little bit like a little symphony, right? And I just said to him, I said, I just love that we're starting to see this kind of more elevated thinking around the peptides. Because, those of us who've been around peptides for a while, we're starting to sound like a broken record. Like, BPC 157 on its own is fantastic, but it's not going to do it all. And so now we have people starting to think that way and saying, okay, what else can we bring in to complete the picture, as it were?
Yes, absolutely. That's brilliant. I'm so glad to hear he's doing that.
Yeah, no, me too. So unfortunately, we're kind of at a time which I feel really, I want to keep talking. So we're going to do a part 2, because I think what we'll do part 2 is maybe get a little deeper into the GI testing.
That'd be great.
And that kind of stuff. And, but maybe we'll leave it at that for today. And maybe Suzanne, you can tell people where they can find you and
yes,
how to get in touch if they so feel, even though you've got a very deep wait list, nevertheless.
Yes, we're in Atlanta, right around Atlanta. We're just outside in the suburbs of Atlanta. And I have 2 nurse practitioners who have been trained by me, who work for me. You'll actually get to hear me and one of my nurse practitioners speak. She's been with me now for 8 years. And so both of us are speaking at ACOM in Salt Lake City in, it's July 9th, 8th, 9th, and 10th. It's an ozone and peptide combined conference with some live demos. We have a really great esthetician who's going to come, and not esthetician, I'm sorry. She's a nurse practitioner injector. She's going to come and do some peptide training on aesthetics.
Yeah. Actually,
and some live demos.
Yeah. We're going to cut that part out because this won't come out in time.
Oh, okay. Never mind.
This isn't live. Do you have another one coming out?
I'll be doing the peptide conference in September. It's the 13th, I believe, whatever that second weekend in September is. That will be part of A4M.
Okay, so
it's peptide certification. That is Peptides 2, I believe. I forget it is Peptides 2 in September. That'll be in Boston.
Okay, in person?
In person.
And is there a virtual option to that?
There is you can buy the audio recordings.
Okay, cool.
Yes, absolutely. And then I'm on Instagram and on Facebook, and you'll find me on Natalie's sometimes answering questions for her when I have a minute.
Dr. Turner shows up. It's amazing. And then it's Vine Medical is the name of your clinic?
Vine is in Grapevine, yes.
Love it. And on Facebook, Instagram, is it Dr. Turner, Dr. Suzanne Turner?
Dr. S. Turner, DRS. Mm-hmm.
DRS Turner. Perfect.
Yeah.
Then thank you so much for your time today.
It's such a pleasure, Natalie. Always so great to see you.
Thank you so much.